Good afternoon, everyone. Thank you so much. If we could get seated so we can start the panel. All right, I am Dr. Megan Thompson, Senior Health Policy Advisor for Congresswoman Robin Kelly, and the CBC Health Braintrust lead. I am excited to be a part of this discussion with this esteemed panel today. We will be talking about the mental health. So hopefully all of you are here to discuss this and learn from some frontline clinicians who are doing a lot of great work in this space. So the title of this session is Needs of the Underserved and Disenfranchised. Millions of people in the United States are affected by mental illness each year. It's important to measure how common mental illness is so we can understand its physical, social, and financial impacts. And so show that no one is actually alone in this fight. So here's some quick facts. 1 in 5 U.S. adults experience mental illness each year. 1 in 20 U.S. adults experience serious mental illness each year. 1 in 6 U.S. youth age 6 to 17 experience a mental health disorder each year. And then when we break that down by race, the facts are even more alarming. 16% of those who identified as Black or African American reported having a mental illness in the past year. This is over 7 million people, and I'm a very visual person. So that means that is the population of Chicago, Houston, and Philadelphia combined. The suicide rate among Black people between 2018 to 2021 increased by 19.2%. The quickest rise happened among just 10 to 24, with the suicide rate among Black youth rising by 36.6%. 2 more quick facts. At least 8.4 million people in the United States provide care to an adult with a mental or emotional health issue. And caregivers of adults with mental or emotional health issues spend an average of 32 hours per week providing unpaid care. And in 1 year postpartum, suicide and substance use are the leading causes of maternal deaths, with suicide accounting for 9% of the maternal mortality rate. Maternal mental health conditions such as anxiety, perinatal and postpartum depression, birth-related PTSD are the most common complications of pregnancy and childbirth, affecting 1 in 5 women. Among those affected, 10% go untreated. So these are pretty depressing statistics, but I want you to grab onto hope, because when you hear from this panel and all of the amazing work they are doing, you will leave with a renewed sense of dedication to improving access to mental health services. So let's get started. Once again, I said my name is Dr. Megan Thompson, Senior Health Policy Advisor for Representative Robin Kelly and CBC Health Braintrust. I will let the panelists introduce themselves now.
Great, thanks so much. My name is Jason Resendez, President and CEO.
Your mic's not on. Try it now.
Can you hear me now? Test, test. Nope.
Keep going.
Okay, well, my name's Jason Resendez, President and CEO of the National Alliance for Caregiving. We're a membership-based organization that brings together 60 institutions from across society around research, innovation, and policy initiatives to build health, wealth, and equity for America's 53 million unpaid family caregivers. I look forward to contributing to the conversation.
Good afternoon. My name is Jashawn Mance. I'm Associate Professor of Psychology at Howard University. I'm also the Director of Clinical Training in our Clinical Psychology Doctoral Program. My research focuses on child traumatic stress, race-related stressors, and community-based participatory research. I'm very happy to be here. This is a topic that's near and dear when it comes to making sure that services are provided to those that are marginalized and underrepresented, underserved. It's definitely a passion for me, as well as our students at Howard University.
Good afternoon. My name is Jamita Nicole Barlow, and I'm an assistant professor of writing, health policy and management, and women's gender and sexuality studies right up the road at George Washington University. I am trained as a community health psychologist, as well as a scholar in women's health. I have a background in many different areas, but what I do is I do a lot of community-based research, engaging community, listening to community, and working with community to create solutions with and for community. And I'm excited to be here to talk about this mental health crisis and to hopefully strategize together.
And my name is Josue Guinard Carreño. I am here representing Biogen. And a little bit about Biogen. It's one of the leading biotech companies in the world, really focused on several neurological diseases. So that we have treatments for multiple sclerosis, spinal muscular atrophy, Alzheimer's disease, and we are currently pending an FDA review for zuranolone, which is a treatment for major depressive disorder and postpartum depression. And I'm personally at Biogen because of the patient-first philosophy the company has. And when we hear the unmet need in the mental health space, it's pretty exciting to be able to be here to talk about how we can kind of improve outcomes for patients.
All right, thank you so much. Well, let's get started. So, anybody was not aware that COVID-19 was here, and it created a lot of isolation, a lot of anxiety, a lot of mortality that we had to face head on in huge ways, continuously seen in our face. Anytime I turned on the news, there was a ticker, like a football game, about disease and death. And I think it was the first time a lot of us had to realize and see disease and death so much in the forefront. So let's look at the landscape of mental health services in this country. I believe my panelists will say we don't have enough resources, but Dr. Mance, can you just kind of give us an overview of like what you're seeing, what you're feeling, hearing in our society about the resources that we have?
Absolutely. One of the things when it comes to not only providing services, but I want to look at the other side of it as well when we're having this conversation in regards to how we are training our professionals. Right. So, of course, there's been a lot of conversation and a lot of attention because there's an upsurge in mental health needs where the need has always been there. But it was like the pandemic or those dual pandemics in regards to the racial unrest and this, social justice issues, along with COVID, really just kind of tore up this Band-Aid that we've kind of placed on these issues. So when it came to mental health, you had this upsurge in individuals who are seeking mental health that may traditionally had this aspect of stigma around mental health, really kind of coming forward and seeking services. I had a lot of emails in regards to providing services saying, hey, at Howard, do you all have a community clinic? Excuse me, are there services? Can you refer me to someone? As well as in my private practice. So one of the things that became very, very noticeable is that, okay, we're going to have to be able to provide services in a way that can be received by the communities that we're servicing. Also, how do we create this container to make sure that we're training our psychologists, our clinicians, mental health providers to be able to meet the need of those that are historically marginalized and oppressed in a way that's not just putting a Band-Aid on it, right? But then also kind of creating the container for the mental health providers needing attention themselves, right? So when it comes down to this landscape of what mental health services and what what does it look like now, is that I don't even think we've begun to even hit that precipice, if you will, in regards to what the need will be.
Anybody else want to jump in?
Yeah, I just want to add to that. We need to do both the training of professionals, but I want to add that 2% of current workforce are Black psychologists. I work primarily in Black communities, and 4% are psychiatrists. So there's a lack in terms of even people who have physicians or psychologists that look like them. So we have to think about mental health differently. And so that means working where people are. So some of the programs I'm involved with and people that I'm connected with, they're doing work like training hairdressers on how to be that first stop to really engage where people are going regularly, or training barbers. So we have to look at different ways in which to reach people so we can normalize mental health, because the workforce issue is there. Yes, we need more training, and I support that. But we also have to think about where people are every day and how we can normalize this. Because I think since the pandemic, people have normalized what my students call that soft life, living a different type of life that centers mental health. And any way we can do that in our everyday lived experience is essential.
I love that you mentioned finding people where they are. You took one of my questions, but hearing the pastor talk about vaccination rates during COVID-19 was the first time I really saw that true intersect of healthcare in my community where I am. Typically, I have to go somewhere, and so that was very important. I think it increased our susceptibility to be compliant with what was being promoted at that time. And, coming out of this pandemic, we're seeing a lot of what we're hearing, like the long COVID and people now being more disabled. And I think about now the mental health of the caregivers. And so I would love to about what is the current status? Because a lot of times with the data, we have an underrepresentation of the numbers of caregivers, because we typically just say, oh, I'm just helping my friend out. Oh, I'm just bringing them some soup. Oh, I'm just going over there and helping do laundry. Can we speak more about caregivers and what's going on with their mental health?
Yeah, absolutely. And to do that, I want to first start with a question, turn it over to the audience. By show of hands, how many folks in this room have been impacted by caregiving, either as a caregiver or know someone in your life or family who helps to provide care? Wow. So I'm always shocked but never surprised by the answer to that question, right? Caregiving is something that connects all of us, yet in this conversation about meeting people where they are, that's a huge barrier for family caregivers because of that lack of recognition, that lack of structure for recognizing, supporting, and ensuring that family caregivers get connected to resources. And when we think about the numbers, for the folks who raise their hand, Americans providing unpaid care in this country for a loved one. Nearly 36% report high levels of emotional stress due to their caregiving responsibility. About a third of Black Americans report emotional distress due to caregiving. And now I have a mic, so watch out. About a third of Latinos also report emotional stress due to caregiving. Over 40% of Asian Americans report emotional stress due to caregiving. So there's a huge impact when it comes to, one, family caregiving and the invisibility of caregiving, but then two, the disparate impacts of care on communities of color. And so when we think about, well, what does that translate into, right? That translates into poor health outcomes for family caregivers. 23% of family caregivers report that their health is worse due to caregiving. That's 12 million Americans who say that my health is worse off due to my caregiving responsibilities. And it's those Americans that are more likely to report mental health challenges due to caregiving. So there's a tremendous need to, one, recognize and value the role of care, value the work that they do. I mean, the work that family caregivers provide has been estimated to be around $600 billion a year in labor. They're an extension of the workforce. When we think about, well, how do we address some of the workforce gaps that we see in promoting mental health in our communities? Family caregivers, in a large part, are doing that. But they're not doing it with training. They're not doing it with support. They're not doing it with even models of reimbursement. So in the family caregiving community, we're looking a lot at how community health workers are mobilizing themselves in providing and serving as a bridge for health, including mental health, into communities. So there's a tremendous amount of work that needs to be done in order to support unpaid family caregivers and ensure that that we bring value to the labor that they provide and also to the benefit that they provide to our communities, to our economy, and to the health system.
Okay. Thank you for that answer. And so, Jose, I want to turn it to you and just say, what is Biogen doing to address the challenges in mental health, and how can industry support efforts in this space?
Yeah, thanks for the question. I would love to comment on the caregiving question just for a moment.
Of course.
So I think you presented a really compelling part of the caregiving equation, and the other part is to the patient that's suffering from a mental illness. The caregiver also takes quite a burden from that. And that's one of the reasons that patients really struggle with certain mental health illnesses like depression or postpartum depression, where you are relying on your caregiver a lot of the time. And if the treatment doesn't resolve, whatever the mental health issue is, let's say it's depression where 2/3 of patients don't see relief after their first course of therapy, that burden on the caregiver continues over time. So caregivers are critical to patients suffering from mental health issues. So to the question that you actually answered, sorry for that. The way I'll respond to that is there are probably two ways that we're looking at it from an industry perspective. I think first, it's kind of understanding the unmet need in the mental health space. And then the second part of my response will be around kind of what we're doing, what our approach is based on what we've done in the past in other therapeutic areas, and kind of what some of the foundational work that we have to do still is. So the unmet need, as you mentioned earlier, in mental health is huge. So not to reiterate some of these figures, but 1 out of every 5 adults in the US in their lifetime, or 1 out of every 5 individuals in the US in their lifetime will experience depression, which just like almost everyone had experience as a caregiver, many people either have experienced themselves with depression or know someone. And the statistics for postpartum depression, which is depressive symptoms after or during birth, or shortly after or during birth, is around 1 in 8. So it's huge. And many of the patients that go on therapy don't see resolution. 2/3, as I mentioned earlier, don't see resolution of symptoms. So there's a huge unmet need. And there's a lack of innovation in the space as well. So, Biogen's really compelled by this huge unmet need and the opportunity to create an innovative therapy that could, resolve symptoms quicker and without something that requires chronic treatment over the long run. So I think that's the unmet need. And I think beyond just, the need for therapy, there's also the need to kind of address stigma. Some of the systemic barriers that, beyond affordability, insurance, some of the systemic barriers like cultural barriers, like in many cultures, especially in Latino or Black communities, there is a bit of a resistance to seek treatment. So I can say for the Hispanic community in particular, in the US, around 60% of patients or people diagnosed with depression actually seek treatment. Within the Latino community, it's around 40%. So there's a huge disparity there in the willingness to seek treatment. Some of that is stigma related, some of it is access related. And so how do we address this? I think from a Biogen perspective, the way that we think about it first is trying to find the data, trying to better understand what the needs are in the community. So in clinical trials, representation matters tremendously. So for example, in some of the clinical trials in mental health, we do have robust representation across Hispanic and Black communities, which is important to better characterize the safety and the efficacy of a treatment. So that's critical there. And then on the other side of the equation, how do we make an impact? So we're relatively new to the mental health space, but in the past we have established several partnerships to better reach the community. So a couple examples are through the National Association of Free and Charitable Clinics. Biogen has partnered with them to ensure that these 1,400 clinics can reach millions of patients with better access to the drug. And then lastly, sorry, I just lost my train of thought.
It's all good.
I apologize. And then lastly, other partnerships like with NMQF, ensuring that we are finding providers in the areas where they are serving their communities. So we do that to better inform our clinical trials, but also to help better inform treatment needs in different areas of the country.
Amazing. And one word that I keep hearing as the panelists talk is stigma. Stigma, 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 especially in our communities. And so, we have to take the time to applaud various leaders like Senator John Fetterman, who is actively showing the nation what it looks like to say, I'm not okay and I need to go seek help. And then, seeing the smile afterwards to say, hey, I sought out treatment and I'm doing better. So we kind of saw like the full continuum there. But what are additional ways that we continue to remove the stigma that is associated with seeking mental health services? So anybody? Okay.
I actually want to, Jamita? Mm-hmm. I actually want to circle back around to some of the things that Jamita mentioned and some of the work that she's doing in regards within the community. So one of the things that at Howard, when we're training our clinicians and even as a licensed psychologist myself, is kind of thinking of innovative ways. And what are those innovative ways? What are the day-to-day things that folks are using that we can optimize and utilize and be able to disseminate information, but then also to make our services accessible? So some of them are essentially kind of meeting communities where they are, going into the communities, but also things like virtual reality. So we use virtual reality in regards to teaching cognitive behavioral skills. So essentially, this reality of you're placed in this scenario, teaching young people in regards to how they would respond and being able to teach the skills that they need when placed in a specific scenario. Also utilizing apps. So being able to give them access to apps, free apps, make sure. Free apps that will be able to train and give them information. I have a list that I provide to the communities as well as for clients. But then we also use peer models. So peer models is essentially when I'm working within communities. So essentially what we're doing is working with I work with emerging adults. So we train our emerging adults when it comes to psychoeducation, just information about a specific topic. And then they in turn will essentially then train their peers. So they're using this kind of peer mentorship model, but they still have a licensed professional that they can come back to and be able to make sure that they are, that the need is met and we're able to make the proper referrals, right? So we're not necessarily saying, hey, you're the clinician, but making sure that we're extending what services look like, how we engage just different folks.
And I'll just add to that, another way to figure out ways to reduce stigma is to think about what's happening structurally in our workplaces. You see this happening in some places where they're having more days, like if people have returned back to in-person, they're having more days off, they're having mental health days or mental health Friday or mental health Monday. So really thinking structurally how we can really normalize the importance of taking care of ourselves. I think everyone throughout the pandemic has understood trauma. I study trauma. And so understanding that there are multiple levels of trauma. And so the one that we all share is having lived through this pandemic, still living through it. And so combined with other traumas that our communities experience, having ways in which we can engage on a daily basis where mental health is focused. And so there are a lot of little things that people can do to reduce stigma. But part of it, when I think about it structurally and at the policy level, is that we normalize it by giving days off, by having events where people can really focus on mental health. And that looks different for everyone. Not everyone wants to practice yoga and meditate. I like it, but not everybody does. So finding what that is for everyone and normalizing the importance of that and how our lived experience is contributing to our mental health. So not separating them.
If I could just jump in, I totally agree with Jamila about the importance of thinking about workplace infrastructure to support mental health and address stigma, and the policy that needs to be in place, not just the institutional policy, but the federal level policy that we need to in place to help address stigma and also to improve care and outcomes for other conditions and issues and health disparities. We're one of the only industrialized nations in the world that doesn't have a national paid family and medical leave policy. So when we talk about days to recognize mental health, this shouldn't be a corporate benefit that's available to the Biogens of the world, but not to the folks that work at McDonald's, for example, right? Mental health is a challenge that impacts all of us, just like caregiving impacts all of us. So paid family and medical leave can be a really powerful tool for ensuring that folks have time to provide the care that they need, either for themselves and dealing with a complex medical issue or the care for a loved one. So I think it's that combination of workplace culture and workplace policy that can take us, far, but not far enough. I think that's where we need federal level intervention with a national paid family and medical leave policy.
And it be enforced.
And it be enforced.
Did you want to add?
Yeah,
to that?
and not to belabor the stigma topic, but I guess I liked how when you asked the question, everyone kind of looked at each other, because where do you start with stigma? It is such a huge issue in the mental health space. And one other way that we've been thinking about it is from, the start. So one of the things that prevents patients from seeking care or even from kind of accepting treatment is when they see a provider that they feel doesn't really understand them. So that's one of the things that we need to kind of address as a society at large. Like, how do we increase representation amongst healthcare providers of diverse communities? And, from the Biogen perspective, it's difficult for a company to do this, but a small way that we've been doing it is through community labs. So we have a community lab in Massachusetts and another one in RTP, and we have a virtual one where we engage middle and high school students and connect them with Biogen scientists to help, provide hands-on learning in like a cutting-edge laboratory environment. And so that's one small way that you can start to kind of nurture STEM education and encourage a future generation of providers from diverse communities.
I love how you spoke about like apps and technology and things like that. And one of the influencers that we hear so much about regarding youth mental health is social media. Influencers just put a very curated picture and perspective of their lives, and we don't get to see the behind the scenes component of what's going on in people's worlds other than what they want us to see. And so is there a way that we can do a better job at, navigating these algorithms to make sure we're promoting positivity and well-being? One of my favorite things is when I'm randomly scrolling through social media are those posts that are like, take a deep breath, 4 seconds, hold for 2 seconds, now release it. And, just feeling that tension leave my body and just have a moment of mindfulness. Are there ways to bolster that type of platform and things in social media so our children and adults and our caregivers can see those mental health well-being reminders?
Yeah, I think you see it happening all over. There's so many different influencers who are doing that type of work, whether it is the meditation and living life differently or sharing their daily, I don't know what happened, sharing their daily experience. And as a result of that, you see people taking that in. But I also want to just point to how social media, we've seen has contributed to the increase that we're seeing in mental health issues. Depression and anxiety are up, suicide are up, more so during the pandemic, but particularly among young Black girls. And it's in combination with other issues. I think that's where this is so important, finding a way to use social media. They're already there. And you see a lot of interventionists and health behavior work really trying to figure out ways to engage different populations using social media. And apps are involved, different types of online digital tech are involved. But I think there's a very fine line, because the danger is it's also contributing to this idea of the ideal body image that we've talked about for a very long time in terms of its contribution to eating disorders, but also how it's contributing to the quest to be perfect. And so now we have this increased desire to live a certain lifestyle. And if you don't have that lifestyle, a lot of young people are really having a hard time.
No one else wants to jump in right there?
Yeah, I definitely say it's that balancing act, right? Of the beauty and power of social media to help folks find community and see themselves in these issues, whether that's going through a mental health challenge. When we talk about stigma, the power of seeing yourself and seeing someone else go through something similarly can help to address stigma. We certainly see that in caregiving, where there's just an amazing community of online content creators who are sharing their caregiving stories from all cultures and walks of life. And I think that's important to help us raise awareness and visibility and self-recognition of caregiving. Within mental health, though, I think it is that fine line, right? Sort of understanding how do you preserve and cultivate that meaningful and authentic voice, while at the time look through policy and dialogue. What are the guidelines, right, that are going to help us preserve that voice and that authenticity without, perversing it in a way that's contributing to the mental health inequities that we see in this country. So I think there's a really powerful conversation happening right now in DC around what the role of guidelines and norms and best practices are for social media and for digital content more broadly. I think that's one that I think needs more content creator, policy experts of color to be part of that conversation, given the inequities that we see from a mental health perspective.
Amazing. I am going to direct this next one to you to start off with, because you alluded to the issue of trying to identify caregivers, but also what are those wraparound services and different models of care that we need to support in order to make sure caregivers are supported?
Yeah, I think that's one of the challenging aspects of caregiving, right? Because caregiving impacts every aspect of our lives. So we know from our data that caregiving has consequences. Some of those are positive consequences, like over half of family caregivers report a sense of self-purpose from the care they provide, and that's particularly high among Black, Latino, and other caregivers of color, particularly women of color. And that sense of purpose actually helps to buffer some of the emotional stress that we see in the data. So there's a sense of resilience there that we start to see in the data that needs to be better explored. At the same time, we know that caregiving has consequences from a healthcare perspective, more likely to miss going to preventative care appointments, has economic consequences. Over half of caregivers experience at least one negative financial impact due to caregiving. So there's a range of impacts that need to be addressed through wraparound services, through better access to healthcare interventions, to mental health supports, to economic supports, to promote financial security. But one of the big issues to actually ensuring that happens is that identification of a caregiver. So from a healthcare perspective, for example, there are very few systems that are actually identifying whether or not a patient has a caregiver. Providers are not asking about, and we know this from our data, providers are not asking their patients whether or not they have a caregiver. And if they do ask the patient about a caregiver, they're not engaging with that caregiver, asking what those caregivers need to better support care. At the same time, we see a lot of rich data on, similar to what Jose was talking about earlier, that when you take care of the caregiver, you're also taking care of the patient, and outcomes are better. So it's that importance of, well, what is the infrastructure that we need to be in place? One is, how do we integrate caregivers into electronic health records? How do we integrate caregiver perspectives into value-based assessments for health systems and for providers? There's about reimbursable billing codes to promote caregiving. So I think there's a lot of opportunity. It's very fragmented, and it's all about how we start to reorient the system to center caregivers way more than we are today.
Add to wraparound services and additional needs.
Thank you.
Caregiving in action.
Caregivers. Can we talk about your needs in Biogen regarding clinical trial diversity and ways that we can increase access in our communities to make sure we are more aware of the trials and the studies and the research that is going on, so we could be more participatory in it?
That is a great question. And I think, as I mentioned earlier, at Biogen, clinical trial diversity is critical so that we can better understand how our treatments, affect patients, both the good and the bad. So that way providers can feel more educated as well as to how to think about, the pharmacological impact on these different communities. And so how we think about it is, as I mentioned with NMQF, we do have a partnership where there is a database where we try to identify where patients are and ensure that we are, establishing clinical trial sites to be able to recruit in these diverse communities. And through this partnership, we're able to, through these clinical trial sites that are already there, they are one of the main sources of being able to kind of better reach these communities. But then beyond that, there's also local community outreach, advocacy group partnerships, and also just direct outreach to patients as well. So there are a number of ways that we kind of actively recruit and try to ensure that our clinical trials represent the communities. I think lupus is a great example where epidemiologically, it disproportionately affects women and women of color. And so, that's one of those examples where this partnership with NMQF has been successful in being able to ensure that we're getting, a representation of the patient population in our trials.
No, thank you for that. And, as we're sitting here and I'm thinking about the numbers, it's like, how do we also ensure that our first responders know how to respond to mental health crises? And then as they're going out and responding to these, how do we double down and ensure that they have the access to mental health wellness that they need? So I would love for you to speak more on that.
Thank you. Okay. Hopefully I'll be able to get through it. Thank you so much. Thank you so much. I was like, my eyes are watering. Everything's going on here. Thank you. So the great question. One of the ways in which, just for myself and my research, I am partnering with first responders in Alexandria, Virginia. And this partnership came about through a community organization, the Concerned Citizens Network of Alexandria, in regards to wanting to address health equity and really kind of understanding how do we not only engage our first responders, but make sure that they have the information needed in order to go into communities and engage communities in a very helpful way and not necessarily creating more trauma for the communities and for themselves. And so part of that is not only education, but also awareness. So making sure that they have the information in regards to recognizing their own sense of trauma and mental health needs, because there are certain professions in which recognizing and giving voice to your mental health needs, there's further stigma, right? And so, for example, for law enforcement, if you're saying that you have mental health needs and you need to have that engagement, then you're at desk duty now, right? Same for firefighters. And so part of that process is thinking about how do we normalize the discussion? How do we begin to kind of just dismantle some of the stigma around mental health for these first responders, that particular workforce, but then making sure that we can implement policies. It kind of goes back to the earlier discussion that I wasn't able to partake in because I knew I was going to start coughing if I did. Just making sure that we have policies that allow us to make room for mental health providers, not only just EAP programs, but why is there not a psychologist, mental health licensed social worker part of that workforce? Some have them, but not all. So I'm partnering with the sheriff's department first, but I'm also partnering with the fire department, and they don't have fire department and the sheriff's department. They have mental health professionals. They do have some psychologists, but when it comes for the officers themselves, there's a limited number. And so really kind of providing those services and making sure, again, that we are having a discussion, having a sense of awareness, not stigmatizing those by putting them on desk duty or minimizing their abilities to be able to do their jobs, right? We don't want to penalize or punish someone because they're saying, hey, I'm not okay. And then you get sidelined. So we definitely have to have those discussions. We have to be able to have a container where our first responders can say what their needs are, because that we've all had big T, little t, I call it, at different levels of trauma. I call it big T, little t. And depending upon what may be a little t for me, may be a big T for you, but we've had this layering of trauma, of traumatic experiences. And just think if that's day to day when you go to work, you're going to have this traumatizing experience layered on just your lived experience and the intersection of your identity if you're a person of color as a first responder, right? And so making sure that we meet those needs as well. So awareness, communication, and addressing policy.
And do we feel like the tools that we've started to see grow more into our country, like telehealth, can we talk about like the impact that has had on being able to provide more mental health services to people in our populations?
I mean, I can try and address it broadly, not so much the telehealth part, because I think that's important. I think you saw an expansion of those technologies being available during COVID for obvious reasons. But I just want to back up a little broadly about why this is so issue, kind of bringing some of the pieces together. When you look at, I mean, you gave a great intro on what was happening with perinatal mental health. And I just want to speak to that a little bit more, because that's one way in which telehealth can really have an opportunity. The fact that not even several years ago, a few years ago, 60% of the reason why we have our adverse maternal health outcomes, so maternal mortality, infant mortality, low birth weight, that was due to the fact that we had underlying issues with cardiometabolic disease, so stroke, obesity, diabetes. That in combination with institutional bias contributes to what we're seeing in terms of the health of pregnant individuals. As a result of that, of what we're seeing happening politically, the daily lived experiences of all individuals, but particularly those who give birth and women, what we're seeing happen now is that people are more likely to die of suicide. That's the perinatal mental health outcome. And if you're not enraged, that is so scary. And part of that is due to all of the other lived stressors that women have, whether it's the intersection of violence, sexism, racism that they experience every day in the home, in their particular communities. And in combination, the rural areas are also parts of the country where hospitals are closing down. So telehealth then represents a way in which they have someone to talk to during that time when you're in your fourth trimester, which, if you're not familiar with that, is where postpartum mental health issues are so critical, where hormones are post having a baby, hormones are higher, and they're balancing out, and you may or may not have support in your family, in your village, or you might not be near the people in your life. So telehealth has many opportunities, but we have to recognize all of these other factors that are making our mental health crisis, particularly for Black girls and women, so much higher, and nobody's talking about it.
Yeah, I would just add on top of that. I mean, I think that the expansion of telehealth was one of the very few positive ripple effects of the pandemic. And I think that rapid expansion was appropriate for the situation that we were in and that we were dealing with. But now we have this, rapid expansion without a clear focus on what is the quality of that telehealth. What are the differences in that quality? What are the guidelines that we have to be thinking about when it comes to telehealth? So I think that's the conversation that needs to be happening right now, particularly when we think about mental health. What does that parity look like in terms of the kind of telehealth tools that we have access to? What are the impacts of those tools? Because we don't want to just think of telehealth as the solution to hospital consolidation in communities, right? Because that's not an adequate response. So I think it's an additional and positive additive tool, but we have to think about what that quality looks like and be asking that constantly.
No, thank you for that. And unfortunately, we don't have enough time. So it's 1:50. So I would love to turn it over to make sure we have time for questions and answers from the audience. So if there's anybody that has any questions, I think they would like you to go to a microphone right there. And I think we have another microphone over here as well. We can start over here.
I'm a little short. Good afternoon. The question that I had was in reference to the efficacy of the screenings for mental health. There is a clinician. Her name is Dr. Patrice Nicole. She does like a series on DSM-V or, DSM-5 for the culture, where it talks about how a lot of these tools and instruments were developed without communities of color in mind. And so, while it's wonderful to have a PHQ-2 or whatever other instrument you may have, asking a woman who has experienced substantive amounts of stress and trauma, is she overwhelmed, is a moot point. She was born overwhelmed. So, and I myself had personal experience with that. Are you more tired than usual? I have a newborn baby. Well, what does that mean? And I'm a pediatric nurse practitioner, so I'm trained to use these tools, but it did not diagnose me when I was going through it. So how do we then translate that to our aunts, our sisters, our daughters, our grandchildren, understanding that these gaps exist?
I'd love to take that question. Yeah, I wholeheartly agree with you. A lot of the work that I do, I talk about decolonizing methodologies, right? So looking at some of these scales weren't validated in our communities. In other words, that means they did not do any focus groups, any kind of trial runs with the surveys in our communities. Depression looks differently. It shows up differently with us. As a whole, as in general. And so understanding that, then that calls upon the researchers to develop and refine updated scales that are validated in our communities. But it also requires those who are providing services to these communities to understand symptoms look differently. And how can I understand that this is their base level? It's already high. And so how can I just work with that? And I think it's a both and, it's not an either or. But you have a lot of calls in this field. And I know I do a lot of work with APA, American Psychological Association, where there is work being done to really address this issue. So I think it's a great point.
Thank you for the question. Over here, the gentleman over here.
Yes, my name is George Redmond. I'm with the National Alliance Against Disparities in Patient Health. And my question is for the tech people on the floor, but also, Megan, you might be able to chime into my question. And it's about, we were talking about mental health disease and the impact of artificial intelligence. And I'm an expert in this area, and I'm very worried about generative AI and how it's going to advance in the future, because we need some kind of standard or regulation in terms of health disparity, particularly with our young people that are using these cell phones. There's mental health disease that's already starting to show up by the use of it. And so I think what's needed is for an organization like this or other organizations to get involved in a regulatory process that's going to manage the data science that are going to train these algorithms. These algorithms are going to be very powerful. They're going to get even more powerful in the future. They're going to make their way into medical devices. And our data is not represented in these training of these algorithms. And when these algorithms become very prevalent in society, they'll be biased. And my concern is that we will suffer from that bias. It's already starting to happen. I think part of the step that we could take is to really educate Congress on what needs to be done on the data science level to monitor how the data is being curated and annotated to train these algorithms to protect our population from the adverse events. And Megan, maybe you can chime in on what Congress can do.
Yeah, I think that there's a lot that we can do, but what I will say is the technology is moving so fast. I went to a briefing the other week, and a lot of the people, the content experts that were going on, were pretty much like, this is bad, and we're not ready to address it yet. And so what you're saying right now is spot on what we need, more education about what this AI is, what is it embedded in, how are we going to see it in the future, so we can start working backwards to figure out what are those guidelines that really need to happen. Because when I was listening to these panel of experts speak and talk, and I think you were listening to the conversation I was having yesterday at my uncle's house. We were talking about AI. It's the little things like it takes about 3 seconds to take your voice and now mimic and bring forth a whole dialogue. So what does that even feel like when you're trying to Maybe talk to a provider. Are you talking to your doctor that's on the other side of the phone? Like, there are so many things and avenues that I don't think we are 100% ready to address. And I think we are really much at the awareness education phase of AI, I can say, from the policy level. But what I will say is we do need to move fast.
And I would just jump on. What I don't want, because I see this happen a lot, is folks that we're not prepared to engage in this conversation, right? But the urgency is clear for organizations like this and the folks in this room, particularly organizations serving communities of color, to be engaged in these conversations. What I will say is, for organizations that have a long history talking about clinical trial diversity, the divide is not too great you can't surmount it, right? When it comes to thinking about AI in healthcare, it's about bad inputs in, bad inputs out. It's a very similar framework to help you kind of orient intellectually around. And as Megan mentioned, I mean, these conversations are happening now, and they need communities and voices of color, particularly healthcare organizations, community-based organizations, to be part of that conversation.
I think one way you can tap into the resource of the minority serving institutions and HBCUs and MIs, because those programs have very strong computer science programs. Those are the people with the knowledge and the coding that you need to tap. You can't go to people that don't know anything about the technology and science to get the solutions. You got to go to the people that know about the science, that can help you craft the mitigation strategy of the risk. I think that's one way we can go about it.
Thank you.
So can I make a comment very quickly? Because I want to comment and just say you're absolutely correct. Just recently, with the Office of Naval Research, Howard University was awarded a $9 million grant to start a center that focuses on artificial intelligence. And so therefore, and I'm part of that center. And so looking at the effective aspect of AI and how we incorporate within psychology has been at the forefront. For example, one of the technologies that we're working on is related to the algorithm in picking up micro and macro aggressions in regards to creating a database in regards to different words that it picks up in order to be able to, it's related to trainings in regards to micro and macro aggressions. So absolutely, when it comes to HBCUs, historically Black colleges and universities, or historically minority institutions, I think they definitely have to be part of the conversation in regards to how do we address and making sure that we are taking into consideration the needs of people of color and BIPOC population in regards to how they may be impacted by this technology.
Over here.
Hi, my name is Ebony Megabo, and I work at the Association of American Medical Colleges and the Center for Health Justice. And my question revolves around like decolonizing mental health. I had a psychiatrist and a therapist that I liked, and I ended up having to fire my therapist because she tried to Baker Act me. It was like a whole crazy situation. And I wanted to hear from you all about the ways that we can break down the stigma about seeking help. If the risk is always like the police could come kill you, you could be Baker Acted, you could be institutionalized beyond like the 72 hours even. Like, what can we do as far as stigma and the very real risk that creates the stigma?
I can take a stab at this. Yeah, I mean, that's kind of my soapbox, right? When I look at mental health, I'm looking at it through this lens of the interface of criminal justice, the interface of the researcher in me is looking at that as well. I just read about a case on Capital B News that a woman in Fayetteville was shot 17 times in the back. And the local cops they have whatever the term is, they weren't allowed to release the tape. And she was in crisis because her partner had been abusing her, and the cops there's nothing you could do to prevent him from coming after her. That's just one example of what so many, particularly Black women and girls, are experiencing, is this interface of violence, criminal justice, and mental health. And I don't separate it. And so to your question, what does it mean to decolonize? Well, it means that even we definitely need to call on federal government for better policies related to these things to strengthen existing policies. But I would also say that even with some of these policies, there are many gaps. And so that's when I call on our community organization, that we create better tools, better programs, better community outreach that allow us to do that. And then we call upon our researchers to look at some of these practices. To the last question that the woman had, it is akin to clinical, not including Black people in community and clinical trials. Using a scale that hasn't been validated in our community and using it on us is violent. And we have to look at it that way. We would not do that. And so we have to really reimagine what does mental health look like and not use an approach that that has been put forward to us in a lot of our training. And so groups like the Association of Black Psychologists, Community Health Network, there are groups that are doing this work. And so it's engaging with them. And I have a ton of resources that I'm happy to give you, but those organizations have them as well. And I highly recommend reaching out to them. But I really think it's calling on these multiple layers of inserting mental health and not negating ritual and other ways of knowing that might be non-Western.
Thank you.
Yes, ma'am.
Hi there. My name is Shika Danyo, and I work at Travere Therapeutics. I have a comment and a question. I wanted to comment and give a shout out to the National Alliance for Caregiving for all of the amazing work they do on behalf of caregivers. So thank you, Jason. I also wanted to talk a little bit about the pipeline of mental health providers of color and to really understand from those on stage and in the audience, what effective pipeline programs have you seen, and what are your concerns about the future of addressing these issues as it relates to future professionals of color?
That's a great question. When it comes to the pipeline for mental health providers, so being the director of clinical training at Howard University, one of the things I told my students, so this kind of goes back to the previous question as well, in regards to kind of decolonizing, but then also making sure that we have a pipeline for providers, is essentially ensuring that that there is exposure to, whether it's research, there's exposure to the field. So whether that is internships, whether that is being a part of labs at the undergraduate level, because you have to have that experience in order to be a viable candidate at the graduate level. And so also kind of changing how we think about what is the criteria for graduate school. So Howard University and a number of universities have done this since the pandemic. If we don't require the GRE, there are other metrics that we can utilize in order to determine whether a person is ready for graduate level studies, right? But then also part of the curriculum, particularly at Howard University, it is grounded in a number of our theorists, so based in Black psychology. So we're going to talk about doing the work with Black populations of people of color. The theory and how we're understanding these issues have to come from a lens that is rooted within the culture, right, in order to be able to really be effective. And so that's part of one of the very innovative and authentic aspects of our program, is that we're creating opportunities for our undergraduates to be a part of whether it's research or making sure that we have partnerships. We have partnerships with Johns Hopkins, the University of Michigan, a number of larger institutions or PWIs, in order to make sure there is a pipeline for training so that our students can get the experience that they need to meet those criteria that we personally may not necessarily, we use different metrics, but other programs are not, right? And so we have to get in the door to have a seat at the table so that they can be awarded the degree, so that they on the other side can be able to be providers. And when I tell my students in my graduate program, on the very first day in orientation, I tell them, you are needed, you are needed, you are needed. Write your why down, post it, because there are going to be times when you're going to come back to this program and you need to remember your why.
And if I could just jump in, because I want to borrow from some. First, thank you for your kind words and partnership. Something that Jamila said about the need to,
Jamita.
to reimagine what this could look like. And I think that's the same thing when it comes to provider training. We have to reimagine, when we think about it from the caregiver perspective, we'd love for providers to be educated about the role of the caregiver and as part of the patient journey and as a population of themselves. We've issued a report around thinking about caregiving as a public health issue and thinking about it through a public health lens, which underscores the lack of training that providers receive in recognizing caregivers and their roles and the potential risk associated with caregiving. So I'd love to see that more integrated into provider training. I think that could help address some of the challenges we're talking about.
We're going to take your question. I think it will be the last one as we're coming up on time.
Hi, I'm Angela Hayes Talber, and I spent 38 years in the public health. But my question is more of a personal thing. Just from the panel discussion today, I think there is a population which I really did not hear about, and that has a lot of mental health issues in silence. And those are a lot of the seniors who are living alone in their own home. They're not in apartment situations where they would run into other people. Their neighborhoods have totally changed. Their longtime neighbors have passed on or moved or whatever. They have cultural diversity in the neighborhood. And I'm talking about specifically Washington, D.C., because I'm a native from Washington, and our neighborhoods have changed and over time. And also with the crime, they're afraid now to sit on porches. And so their only outlets are, some of them have each other that are in other neighborhoods. There's transportation issues, and they need some kind of support service. And so I think that's an issue that you really need to look at in terms of the policies, in terms of steering funding to programs, more transportation programs, more connectivity programs, doing it through more the recreation, maybe centers or whatever, to make them accessible, because that really is a population that suffers.
No, agree very much. Thank you for that statement. So I just want to leave it up to the panels for 1 minute each to just give closing remarks and any final last thoughts.
No, thanks for joining me. And I just have to agree with what was just said. I think that is an absolutely important community for us to think about. And would just challenge everyone as you leave to think about the caregivers in your lives and what more you could be doing at a system level and at a personal level to support those folks every day.
I would just say, just continue to have the conversations, have the difficult conversations. It's a cliche almost now, but it's very much true that it's okay to say that you're not okay. But it's also okay within your structural, where you are, where you're working, your workplace environment, to make room for those conversations related to mental health, as well as from the training perspective, because I think that's really important. We cannot forget about how we train and we prepare our professionals to serve the communities that are marginalized, underserved, and how we do this work.
And I would say just think about what you do in your everyday lived experience and be okay saying, you know what, I need to take a day and take care of me. Sometimes that can be a model for the people in your sphere of influence. And then that can really progress on at the larger policy level, that we need to center mental health in a way that we don't currently. We can't do anything if we're not healthy. So you push yourself. But if we don't find a way to mitigate this crisis, we're going to see an increase of these rates at an exponential rate, even more so than what they are. And we can do that with each other and in community with organizations that are already in these communities, particularly in older communities. And I think that's so important, who are losing people and have lost a lot of people during the pandemic and feel alone.
I just want to say thanks for including me in this conversation. I've learned a lot even in hearing lots of your comments. And I think is just my final thought. I'd love everyone to just consider the unmet need in this space one more time, and that it's substantial. There are lots of people affected by mental health illnesses. And how do we further educate the community, not just patients, but also providers on this unmet need and what's unique about Black, Hispanic, and other minority communities affected by these illnesses.
Thank you. Well, like I said at the beginning, I know that you are now all reinvigorated, especially on how to tackle this issue after listening to them. So thank you so much for joining this session and have a great day.